Good afternoon, everyone. Welcome to the webinar of the Geriatric Emergency Department Collaborative. Welcome back to many of you. It's been now nearly 4 months, so I hope we've all had a nice summer holiday since the last webinar. My name is Don Milady. I'm an emergency physician at Mount Sinai Hospital in Toronto, Canada, and I'm one of the core faculty with the Geriatric ED Collaborative. Today, we're continuing in our series of webinars about how to create a geriatric emergency department. So we know that a common presentation for older people coming to the emergency department is related to falls. In fact, after abdominal pain, it seems that a presentation for a fall is the most common ED presentation among people over the age of 65. So it's really essential that a geriatric emergency department be excellent at the care provided to those older people who have fallen, to be able to offer a comprehensive assessment to them. And the purpose of today's webinar is to look at some of the research around this topic, and then moving from research to practice, to hear how at least one emergency department has created a falls assessment protocol or program, and some of the outcomes from that. And then possibly most importantly, to hear about the frontline practitioner, the physiotherapist, and get that perspective on what excellent care of a person who has fallen really looks like. We hope that you'll be able to go back to work, whether you're working as a clinician or as a change maker, with some new tips and tricks about falls assessment protocols in the emergency department. We have our usual diverse audience, usually from many different countries, representing multiple professions, including hospital administrators, ED administrators, and even policymakers. So although we advertised for speakers, I do need to let you know that Dr. Tess Hogan from the University of Chicago will not be able to join us today, and we certainly miss her presence. Next slide, please, Laura. The Geriatric Emergency Department is, in case you don't know, is a network of community and academic emergency departments working together to define best practices in geriatric ED care. We do several things. We educate ED clinicians about models of care to improve the care of older people. We support emergency departments and health systems to implement those models of care, and we research and evaluate outcomes. If you share our points of view and interests, and if you're on this call, I assume you do, please join us. Currently, the membership is free. We are putting the link for membership into the chat. And I should always point out that international members are welcome too. The Geriatric Emergency Department is generously supported by both the John A. Hartford Foundation and the Gary and Mary West Foundation. We are very grateful to them for their support over the last more than half decade as we're doing this work that we think is important. Today's webinar is being recorded, and a link to the recording and the slides will be on the website as soon as we can get it there, usually within a few days. As we go along, if you have specific questions for the panelists, please text it into the chat box, and we'll try and have it addressed. As we get started, can I ask if you would all enter into the chat where you're calling in from and what your role there is? It gives us a good idea of who our audience is and helps us serve your needs better. If there will be a drop-down menu, please select all panelists and attendees. So we've got 3 panelists on the webinar today. The first of our panelists is Dr. Shan Liu, who's an associate professor of emergency medicine at the Harvard Medical School. Shan's research focuses on falls in older ED patients, and she's going to bring us up to date on that field. Our second presenter will be Dr. Liz Goldberg, who's an associate professor of emergency medicine at Brown University and also an emergency physician. Liz, at her site, led an implementation project called Gap Care, which she's going to tell us about, and she studied its outcomes. She'll share some of the most important findings that she had from that. And our final of three presenters is going to be Dr. Jessica Babbitt. Jessica is a doctorate-prepared physiotherapist who works in Indianapolis, both as an inpatient and mostly in the emergency department. She regularly sees older patients with falls, and she's going to share with us some of her most important tips and tricks. Next slide, please. We're going to take, before we start hearing from our panelists, we'd like you to think about and answer this question. So, of all the things that you could do, what is the most important component of a falls program in a geriatric emergency department? Would that be screening for risks that may lead to falls in the emergency department? Would it be screening for risks of falls after leaving the emergency department? Would it be having a physical therapist available at least 8 hours a day to the emergency department, not necessarily in, but to the emergency department? Having a policy that all patients who have fallen have a gait assessment while in the emergency department? Having canes and walkers available in the emergency department and for patients to take home if necessary. So those are just some of the components of a falls assessment program. What do you think is the most important? There, I think the poll has appeared on my screen, if you can answer it as you wish. So interestingly, it's sort of an absolutely equal split between 1, 2, and 4. So screening for risks that may lead to falls in the emergency department. That's quite interesting, and we will certainly be coming back to that. Shared with screening for risks of falls after leaving the emergency department, and having a policy that all patients who have fallen have a gait assessment in the emergency department. Interestingly, don't take this personally, Jessica, but number 4 was having a physical therapist available at least 8 hours a day in the emergency department or to the emergency department. And I hope that you will enlighten us all on that. And then very few people chose have canes and walkers in the emergency department for patients to take home if necessary. And interestingly, although only 3 people put that in, I was one of them. And personally, I think that is one of the most important. So I'm going to end the poll there. Okay, and this is, we're going to ask our audience to do a little bit more work here too. Thinking about the place where you work, and I'm going to ask you to put your answers into the chat box. Thinking about the place where you work, what would you say is the biggest single obstacle to high quality falls assessment? And I'm just going to give you 30 seconds to think about that and put in an answer. Okay, so you can all open the chat yourself and see some of the answers that are pouring in. There's quite a wide range of them, and I'll let you take a look at them on your own time. And interestingly, time, staff availability, and even knowledge come up. So next, if you can go to full screen now, please, Laura, thanks. So I'm going to start with you, Shan. You've been studying falls, and I should just say, folks on the line, currently you can either opt for a gallery view where you're seeing all of us. If you want to see our presenters in all of their glory, you can go to speaker view where you would be seeing only the presenter. So Shan, you've been studying falls for a long time. What do you think are the most important findings from the evidence that our viewers should know about? What can we take back to practice?
Oh, yes. Well, I think in doing this work for the last 10 years, it would be that there are more questions to be answered than there are answers that we've actually satisfactorily come to conclusion for as far as what we've done in the emergency department. That's how I'd answer that question. But yes, there are many challenges, but that really translates into many opportunities. So what I'd like to talk about, Don, thank you for this opportunity really, is to talk about and frame the issues with falls and falls interventions in the emergency department. And just briefly talking about the burden of disease, as many of you all know, working in the emergency department, that falls are frequent and that 1 out of every 3 community dwelling adults falls annually in the older population. And approximately 3 million ED visits are for falls. And this is at a huge cost to the US healthcare system at about $50 billion. And what we know is that if your patient comes in with a fall, they actually have already doubled their risk of future falls. So this is a vulnerable population, and falls are really the #1 cause of death due to injury among older adults. And we know that there's a high mortality rate. With our research has shown that approximately 2 to 11% of our patients die within 6 months of their presentation to the emergency department for a fall. So really, I like to think of falls as they're sentinel events, and they really deserve a sentinel response. And of course, I'm probably preaching to the choir, but now that we know and that falls are important and they're frequent, one might be asking yourself, like, what should I do? Where do I start? And I think what you probably want to start off with is like, what type of fall intervention do I want to implement in my emergency department or in my hospital? Is this going to be all patients, all geriatric patients, or are you going to only focus on the patients who are at risk for falls? And the subsequent question to that is, how are you going to screen them? Are you going to actually go through a screening process to determine who's at risk for falls? Or are you just going to focus on the patients who have fallen and come to your emergency department for that fall related injury or their complaint? And subsequently, what you should be asking yourself is, what kind of intervention do we want to implement in our emergency department? Is this largely going to be completely implemented in the emergency department, or is at least part of it going to be done in the ambulatory care setting? And there are advantages and disadvantages to both. One is we control it, it's in the emergency department, we know it can get done, versus really taking advantage of this being a care model that's across the spectrum of care. And unfortunately, the literature in the emergency department literature, we really haven't been able to answer this question of like, who benefits the most from our intervention in the emergency department. We know it's probably not the one that's on palliative care services who is declining and has a terminal illness and lives in a nursing home or is in hospice. We also know it's probably not the 65-year-old marathon runner who tripped doing the Boston Marathon. It's probably somewhere in the middle where that patient has, one study showed that if they have comorbidities, they may benefit from a physical therapy intervention or a falls intervention. But again, like I was saying to Dr. Milady, there are more questions in the falls literature than there are answers. What we know is that there has been a tremendous amount of research that has been developed in the last 10 years, but there's much more research to be done. And a lot of the guidelines that we use that are well established in the outpatient setting, like the AGS, the American Geriatric Society fall algorithm, or the STEADY program, have not been well validated in the emergency department. And so, for example, many of them will say you need to do some type of timed up and go test or a sit-to-stand test. But in my research, only like 30% of the patients can actually get up and actually do a timed test because they came in for a ankle sprain. You know, they came in because they were dizzy, or they came because they had a fever and they just don't want to walk and be timed, and they just don't want to focus on fall prevention. And so our work and our challenge is to actually figure out how to make these evidence-based algorithms that have been done in the outpatient, apply them and figure out what is most appropriate in the emergency department. But currently this international project and effort, which is the Geriatric ED guidelines, we're actually trying to formally grade the evidence. So stay tuned, within hopefully the next year or so, we'll be able to provide at least very rigorous evaluation of the literature to help everyone in this world that is actually trying to do fall intervention. So overall, I'd say there's mixed evidence regarding fall interventions. There have been several large studies that showed significant reduction in falls, but they really focused on recruiting patients from the emergency department and doing the intervention, which was a very intense multifactorial intervention in the outpatient setting, And this is probably around the last like 15 to 20 years. But we are very fortunate to have Dr. Goldberg here, who will talk about a promising intervention that is being done in the emergency department. My next point is also just about barriers and challenges, which you put in that poll, which basically it is not surprising that one of the biggest issues is time. We did an actual survey of providers in the emergency department, and they basically said that they're willing to spend about 2 to 5 minutes doing fall screening and fall intervention. And we know fall intervention takes way more than 2 to 5 minutes. And I actually think it's about 30 seconds to a minute that we're really actually willing to put into it because we're just pulled in many different directions. The second issue is, as many pointed out, that there's a lack of knowledge about what to do. What do I do if a tug test is 8 or a tug test is 20? Our general providers don't know what to do and how to interpret that and what the next step is. And so there will be tremendous effort that's needed to actually educate our colleagues. Unless we're actually going to outsource this in some way, either outside of their emergency practitioners, either to the outpatient clinic or to our colleagues like physical therapy or case management or whatnot. But unfortunately, some of the literature that we've come across or done are that simple solutions like simply referring our patients to the outpatient clinic that specializes in falls is not very successful because patients don't show up. In my study, nobody showed up, and in Dr. Shankar's study, to an outpatient mobility clinic, no one actually showed up. And patients reported that this was largely because, they had a hip injury, or they were still dizzy, or they had vertigo, or they were weak and they couldn't get to the clinic. There's no way for them to get there. And so we know that, unfortunately, just simply writing that referral order at the end of our discharge paperwork is probably not going to translate into very successful intervention. But despite these challenges, I always think of challenges as really these opportunities to make a difference. We've also found that we miss about 96% of the opportunities to actually mitigate fall risk in our patients. And so we have opportunities every day in our patients to actually impact their future fall risk. So I'd say, in summary, like the main challenge with falls is that there's syndromes. So there's no easy cookie cutter program. I really wish there was just a pill that we could give to our patients that would make them not fall. And that would be great. And we wouldn't be discussing this every year. Falls are multifactorial, no surprise. That's what makes interventions difficult. But falls are common, they're costly, we know that they're complicated, and they're sentinel events. And if we don't mitigate fall risk in our patients, they're very likely to fall again. But just like we're on the front lines for all things like COVID and other issues, we're also on the front lines for this very vulnerable population. And so we have just every day the opportunity to actually make a true difference in these patients' lives. Thank you for this opportunity to speak.
Thanks, Shan. Just before we move on to Liz, this idea of a fall being a sentinel event, I mean, that's pretty dramatic statistic that you quoted, that up to 11% will be dead within, I can't remember whether it was 6 or 12 months, but it's a lot and pretty fast. Why, just as a clinician, what's your hypothesis as to why that is? Why is a fall a sentinel event?
Yeah, so oftentimes my mentors will say, that same rug that was there, you've grown up with that rug for 40 years in your house and suddenly you trip on it. And it's because something's happening as we age. We lose our peripheral vision isn't as good. We lose reaction time. We lose strength in our quadriceps. We lose balance. And so it's not just necessarily just quote unquote aging. There are things that happen physiologically as we age that we can reverse. And, it may be that they have a medication that they just started, or they're taking it not as prescribed. And so those are all reasons why patients may fall. So usually there's a reason why somebody falls, and we just have to really investigate as to what's going on.
Mm-hmm. Good, yeah, so it demonstrates why just focusing on the fall itself is kind of not sufficient, but thinking about what's behind the fall, and mercifully, you didn't get onto your favorite topic of the term mechanical fall, which will come up later. That nothing, in short, I think you would agree that nothing in an older person is a mechanical fall, that there's always multifactorial reason for that, and finding out what those things are is going to get us where we want to go. So thanks a lot, Shan. We'll come back. You'll have an opportunity a bit later as well. So Liz, at Brown, you started a program called Gap Care, which has gotten a lot of attention. Can you tell us about what Gap Care is and what were some of your main findings coming out of it?
Sure. Thank you so much, Don, for having me. And that was an excellent presentation, Dr. Liu. I appreciate you framing the problem. We designed a fall prevention intervention in the emergency department because I realized that the majority of patients don't report their falls to their primary care doctors. In fact, in 2018, there was a study of over 45,000 Medicare patients, and only 28% told their primary care doctor that they had a fall injury. So the emergency department feels and is an important place to start an intervention, and we wanted to test if we could do this successfully in 2 of our emergency departments. So we call this intervention Gap Care, the Geriatric Acute and Post-Acute Fall Prevention Program. And what we did was recruit patients from 2 of our emergency departments. One is a level 1 trauma center. We see a lot of high acuity patients. The other one is a academic community hospital with a primarily geriatric population. And we decided we wanted to recruit patients that were 65 and older who had a fall in the last 7 days and were likely to be discharged home. And the reason we did this is because patients that were already in a nursing home facility have resources such as physical therapists and people to help with their medications. But we really wanted to see what we could do for patients in the ED that were going back to a home setting and make that discharge safer. So we recruited 110 patients at these 2 emergency departments, and they were randomized to one of 2 arms. They either received the control, and our control arm had a home safety brochure read to them that talked about home hazards and was based on the CDC study. And our intervention arm received both a pharmacist and a physical therapist consultation in the emergency department. And I want to start by saying we actually did not, at the time that the study started, have any physical therapists in our emergency department on a regular basis. And we also didn't have pharmacists. So this was something that we arranged prior to the study starting by talking to our inpatient physical therapists and pharmacists and arranging that they would come to the emergency department to the bedside to evaluate these patients. And I want to talk a little bit more about what was in the intervention. So our pharmacists would come downstairs, they would meet our emergency departments downstairs, and they would meet with the patients at the bedside, and they would do a motivational interviewing intervention. So we wanted the patient and the caregiver or the family to be engaged in decision-making about the medications. So the pharmacist would do a really brief medication reconciliation, and then they would ask the patient open-ended questions like, why are you on this particular medication? Do you think this medication works for your pain? Would you be open to changing when you take the medication? For instance, for sedating medications, many patients aren't aware that they're taking sedating medications in the morning, and we would change those and suggest that they take them in the evening instead. Or if there was a medication that increased fall risk and the patient said they weren't receiving any benefit, we would suggest to them that they talk to their primary care doctor to stop that medication. And we made very clear to all of our patients that the recommendations that we were making in the emergency department were for them to discuss with their primary care doctor after the visit, and we would not be making those changes directly. In some cases, there were also over-the-counter medications that the patient could stop on their own, and we would encourage them to do so if the pharmacist felt it was safe and the family was in agreement. So after this brief 20-minute consultation, a physical therapist would come to the bedside and they would do a fall risk assessment. So we did the timed up and go test, and we also did a Tinetti fall risk screener and different screens for whether the patient had a gait problem, whether they had a lower extremity strength problem, or they had other impairments such as not using their walker correctly. And then the physical therapist would make a couple of brief suggestions about how they could reduce fall risk and what they should do after they got home. So in some cases, if the patient was very weak or had a lot of injuries, they would suggest going directly to rehabilitation. Whereas in some cases, the patient was a very fit 66 or 67-year-old, and then they would refer them to community fall prevention programs. And then for the patients in the middle, if they were homebound, they might receive a in-home PT evaluation, or they might be recommended to go to outpatient physical therapy. So it was very individually tailored, even though the fall risk assessments were the same. One important component of our intervention was that we didn't want our ED clinicians or our staff to have to take on additional work as part of this pilot program, because we were concerned that if we requested them to spend more time or efforts on these patients doing fall prevention, that it wouldn't be a very feasible intervention. And so we worked with Epic, our electronic health record team, to create templates for the physical therapist and the pharmacist so that their recommendation could go directly into our electronic health record. And the benefit with that was that if the patient ever came back to the hospital, or if they had specialists who worked within our health system, those specialists could see the pharmacy recommendations, or for future visits, they could make those pharmacy changes. And also automatically, when the patient was discharged from the hospital, the PT and pharmacy recommendation went directly to the primary care doctor. So not only did the patient and the caregiver get a copy of the recommendations, but a copy was also sent to the primary care doctor or any specialist they requested they would be sent to. So what did we find? We followed these patients for 6 months, and we did a home visit at 6 months for all of our patients, both control and intervention arm, to see how they were doing, if they had recurrent falls, if we successfully prevented ED visits or hospitalizations, and if they actually accepted the recommendations we made. So on average, we recruited a median age of 80 years old. Our control and intervention arms were equally matched in terms of major demographics. Approximately 15 to 20% of our patients were cognitively impaired, and a third of them lived alone. About 20% lived in assisted living. We checked metrics including feasibility of the study, and one of the things that we were looking at was, do we prolong ED length of stay by doing this intervention? So we compared our intervention ED length of stay to our control ED length of stay, and we found that there was no prolongation of ED length of stay by having physical therapists and pharmacists come to the emergency department. And one of the reasons why I think we saw this, because I get asked this question a lot, is because it takes a really long time to find a staff member or to arrange for yourself to get the patient out of their stretcher, walk them, assess how they're doing after their injury in terms of ambulation and also arrange a safe plan for them to go home. And by having our pharmacists and physical therapists already involved with those patients, I think we were able to not prolong ED length of stay. We saw the same numbers in both arms, the intervention and the control, in patients that ultimately needed to be admitted to the hospital. It was 18% in both arms. And those were mainly people who, after imaging resulted, we found out that they had intracranial hemorrhage, or there was a surprise lab finding and they needed to be admitted. Because we did ask at the point of recruitment if patients were likely to be discharged home. And if the ED physician said, no, they're definitely going to be admitted to the hospital, they weren't recruited. We also saw similar rates of discharge to rehabilitation in both our intervention and control arm. About 18% of our intervention patients ended up going directly to a SNF upon discharge, and 11% in our control arm. We did a survey, and we also did qualitative interviews of patients and families and ED clinicians, and in general, satisfaction with the intervention was very high, and over 90% recommended that future patients should receive this intervention. And now getting to our efficacy outcomes, we looked specifically at whether within the 6-month period that we were observing these patients and following these patients, if we could reduce all all-cause ED visits and fall-related ED visits. And what we found is that we had a significant reduction in all-cause ED visits and fall-related ED visits. So for instance, in our control arm, within the 6-month follow-up, we had 66 all-cause ED visits, whereas in our intervention arm, we only saw 30 all-cause ED visits. And for fall-related ED visits, we saw 24 return visits to the emergency department for falls in our control arm and only 9 in our intervention arm. And although we saw a reduction in events in all-cause hospitalizations and fall-related hospitalizations in our intervention arm, that was not significant. So those are our major findings. I think one of the other things that we measure that would be important to share with you is how is our uptake and our recommendations? Did our motivational interviewing work for our patients? And what we did find is at 6 months, when we asked patients what medications they were on, 73% of the medication recommendations to reduce fall risk were adhered to partially or fully. And the majority of those recommendations actually involved over-the-counter alternatives to medication the patients were taking. Other ones included stopping medications with known side effects or changing the timing of recommendations. In terms of our physical therapy recommendations, 68% of our physical therapy recommendations were adopted either fully or partially. We did note that a barrier to adoption was, in some cases, the patient was recommended to go to a rehabilitation facility and they either didn't qualify through their insurance or they weren't willing to go. And in our qualitative interviews with caregivers, we did find that having the physical therapist talk to the patient and helping the patient realize how injured they were and how difficult it would be to get around at home actually helped them accept the recommendation to go to rehabilitation, compared to in our control arm where patients didn't have the benefit of really recognizing the extent of their injuries and how it was affecting their mobility before they went home. So in conclusion, we did a small pilot of 110 participants that presented to two different Rhode Island emergency departments, and we followed them for 6 months. And we did find a significant reduction in all-cause and fall-related ED visits as a result of a very brief physical therapy and pharmacy intervention in the emergency department. Thank you.
Thanks a lot, Liz. That's really good. And I've got a couple of questions, and I'm just going to park them for you to think about. For one thing, they're in the chat, and everybody's always interested in the money. So when we come back to this, give us some further insights about what the budget for something like this would be. My own personal question, which we will come back, is did everyone get a physio and a pharmacy consultation? And I think the answer is yes. And I'd be interested in knowing which is the more important. And then I'm interested in knowing why you got all of your patients to go to their follow-up appointment and Shan can't get hers or nobody else can. So we'll come back to that. But I would like to move on to our third expert. And it's no surprising that both Shan and Liz have talked extensively about physiotherapy. So now we've got a real live physiotherapist. Jessica's an expert in care of older patients who have fallen. And I'd like to turn the floor over to her for her to go over some of the main things that we can all learn as clinicians and that we can implement as changes in our emergency department. Jessica.
So I'd like to say thank you guys for letting me speak, as this is one of my big passions. I'll be talking a little bit more about the practical side of things when evaluating a patient who has fallen in the ED. So from a PT perspective, it's important to find out where they came from in terms of their mobility, where they are, and where they need to be. We also obtain other traditional social information such as their living situation, their prior level of function, and social support. It's also important to ask about the fall history in these patients to see if we can make an impact on their future falls. What kind of questions do you ask your patients that present to the ED who have had a fall? Also, how about the patients that present to the ED for an alternate reason yet have had a recent fall? One thing that it's important to remember, as Shan mentioned, is one of the primary indicators of a future fall is a past fall. So if a patient comes into the ED for issues other than a fall, but still have had a recent fall, it's important to ask about that. I'm going to give you 4 different questions that I generally ask patients that have fallen. I usually start general and then go more narrow. My first question is to these patients is, what happens when you fall? Sometimes you'll get your answer just with that question. Other questions that I ask if they're having a hard time answering that question is, do your legs give out? Do you get dizzy? Or are you tripping over things? Those can give you more information as to what you might need to do for your patient. If they are dizzy, one of the things that I generally ask them is it room spinning dizziness or is it lightheaded dizziness? That might give you more information as to whether you need to obtain orthostatics or whether PT might be beneficial for BPPV. And then other important questions to ask are about the frequency of falls. So are they occurring all the time, or is this a one-time thing? And also, when did they start? So is this maybe due to a recent medical condition, or is it due to a recent change in medications that the patient has had? Following learning more about their fall history, it's important to do a physical exam. This can provide more information. From a PT standpoint, there are 3 main things that we want to observe. That is, seeing a patient perform bed mobility, transfers, and ambulation. What are some things that you may want to consider when assisting a patient who has fallen with their functional mobility? Well, first of all, it's physical injuries. Of course, we want to protect them. But secondary, you want to think about the emotional impact of that fall. It's important to see their fall, yet protect them at the same time. I always tell a patient that we're going to take our time and we'll only do what you're capable of doing. When we have a patient perform functional mobility, they have to be able to sit before they can stand, and they have to be able to stand before they can walk. So some patients might not be able to come to a sitting position on their own. However, this doesn't always translate into not being able to walk. So when I say you have to be able to sit before you can stand, that means maintain the upright sitting position once you get there. Some patients do compensate for this at home by using recliners to sleep in. Of note, for that dizzy patient, it's also an opportune time to collect those orthostatics. So once a patient is upright on their feet, it's important to see how they walk using their usual assisted device. So it'd be helpful to have a walker and a cane within the ED. This walking should include walking a short distance, turning, and returning back to where they started. A lot of patients actually have loss of balances when they are turning. If they're in the waiting room of the ED and they need to walk back to the area where they're triaged or walk back to their actual room, this might be a good chance to look at them walk. So when you look at their gait characteristics, I want to see a couple different things. I generally look for 3 main things. That is, are they reaching for items? We call that furniture cruising here in the PT world. How wide are their feet compared to their shoulders? And do they pick up their feet when they're walking, or do they shuffle? Patients with impaired balance will usually compensate by either reaching for items or widening their base of support, so their feet will be wider than their shoulders. If they don't have the internal balance, they have to compensate somehow. You might say, well, it's okay, they have things that they can reach for in their home. However, when they get to that open environment, such as the parking lot of a store, it won't work. If they're not picking up their feet or shuffling, that may indicate they have a strength deficit. It may also indicate they have a behavioral modification because they're fearful of falling. However, that also does increase the risk of tripping. If they're displaying these compensations, they may benefit from having a more supportive device than they were using. So for instance, if they were using a cane, they might benefit from using a walker. They'd also probably benefit from having a PT evaluation, whether that be in the ED or outpatient or home PT, to work on their issues. This might even help them progress back to their baseline assisted device. So when prescribing assisted devices, it's also important not to overprescribe assisted devices. Not every 82-year-old that walks into the ED requires the cane. If you do prescribe a cane for every 82-year-old that walks in the ED, you're going to end up decreasing the balance of the people who actually had balance before, because the balance system is a use it or lose it system. If we don't challenge our balance system, of course, not to the point of falling, we actually decrease our internal balance. So another topic that I'd like to talk about is outcome measures that can assist with fall risk mitigation. First, you have to determine whether a patient is ambulatory or not. If they're ambulatory or they can walk, the quickest and most valid test is your timed up and go or tug test. For our geriatric population, If they complete it in under 10 seconds, they're considered freely mobile and completely independent. If they complete it in over 20 seconds, they are considered to be independent for transfers. However, they might need an assisted device. And if they complete it in over 30 seconds, they're considered dependent in most activities and at high risk for falls. That's great if your patient is ambulatory, but what if they can't walk? Well, if they can't walk, the best test to perform in the ED is a 5-time sit-to-stand test, which is basically having your patient stand up and sit down 5 times. With this test, if they perform it in over 15 seconds, they're likely to be a recurrent faller. So that's a little bit about fall risk mitigation from a PT perspective. Now I'll try to answer one of the most important and common questions: is my patient safe to go home? When looking at that from a PT perspective, it's basically a comparison. The comparison is between what they're able to do and what they will need to do in order to go home. A lot of the information about what they will need to do to go home is obtained from your social information from the patient. The information of what they're able to do is obtained from your physical portion. Here are 4 questions that I like to ask myself when trying to determine if my patient will be safe to go home. So from the physical portion, do they need physical assistance with gait or transfers, no matter what assisted device I choose? The next 3 come from the social information that I've collected. Those are, do they have someone at home that is able to provide the help that's needed? Do they have the necessary equipment to go home? And is their home setting one that they can manage? Such as, do they have a ton of stairs they'll need to negotiate in order for them to do their necessary functions? If their current level of function matches with what their home setup is like, they're safe to go home. So for example, you have an 85-year-old patient in a 1-story house, no stairs to get in, that lives with his 48-year-old active son that doesn't work. He requires a little bit of help for transfers. Is he safe to go home? He probably is. However, he might also benefit from PT in order to better himself physically. Now, if the same 85-year-old lived in a house with the bathroom, the only bathroom upstairs, or the 40-year-old active son was his 92-year-old spouse that used a cane for mobility, that would be a completely different situation. So I hope that helps clear up how we can help our patients that have fallen from a PT perspective. Now I'll pass it over to Don.
Thanks a lot, Jessica. There's a lot, I think physiotherapists do a lot of things. Which of those things could be done by somebody else, like an emergency physician? So if you had a chance to talk to the emergency physicians of the world, and you do right now, what are a few things that you know, in a department where one doesn't have access to a physiotherapist, for example, and that's a lot of emergency departments, what would you say to those emerge docs and nurses about things that they could do for older people who've fallen in a time efficient?
So it's basically just watching their mobility. I mean, do they need physical help for anything that they're doing? If they do, does that translate over into their home setting? And or is there something you can do to fix that? Can you give them an assisted device that would help them out with that?
Mm-hmm. So interesting, going back to the initial quiz that we had, a lot of people did mention the importance of a walk test or a gait assessment in the emergency department. And a few of us said having a walker or a cane in the emergency department is going to be an important intervention as well. Thanks a lot. There's a number of questions have come into the chat box, and I'd urge people to take a look at them while you're listening to everything else that's going on here. Laura, can we go on to the case? I've just got an opportunity to think about how we actually put this into practice. So the emergency department chief at a hospital has been told by her executives that the hospital wants to improve its services to older ED patients. They've already got some things in place, but they don't have any way of they don't have a standardized approach to falls assessment. So she comes to you and asks for your advice. What are some key points that you give to ensure that she creates a program that will benefit all older patients who've fallen and possibly will satisfy the requirements for accreditation if you're interested in that? Shan, why don't you start? What do you think is the most important thing to consider?
Well, first of all, just being a reviewer for level 3s, as far as accreditation is, just make sure that you're not just trying to prevent the fall in the emergency department. The goal is largely to do something beyond just inpatient or in hospital fall reduction, because many of those interventions, like keep the patient in the bed and have the handrails up, really decrease mobility. And the patient, of course, after they're in the hospital for 7 days, has become deconditioned. And I see Jessica nodding her head. Yes, you want to get your patients to walk, and the hospital may want you to decrease in hospital falls, but this leads to long-term deconditioning. Sorry about the technical glitch. Yep. And really, you want to get your patients to walk and not get deconditioned and have future fall risk. As far as the second thing that you'd really want to focus on would be kind of identifying your resources. I think basically, do you have physical therapy? Do you have case management? Do you have people who can do safety evaluations in the home? So I think the first thing you would need to do is do a assessment of your resources.
Mm-hmm. And that sort of goes back to a previous webinar we did last May, talking about financial considerations, and I think that's where research like Liz's really comes into play. And if you can make the case, as I think Liz is going to talk about, that this can be a cost-saving measure, your access to resources may increase. So Liz, what would you say are the important things to add to a department's falls assessment program?
I think you could have different answers depending on who you ask. I think if you asked our patients and our caregivers what they valued most about gap care, they would say the very brief pharmacy evaluation, because many of them were not clear that they were taking over-the-counter medications that weren't safe, that there were over-the-counter alternatives to the unsafe medication taking. Many of them actually, so in Rhode Island, it's here in the winter, so we have a fair amount of patients that go down to Florida and have other prescribers in different states. So we noticed when we were doing medication reconciliation that we had some patients that had 3 different prescribers, none of which were talking to each other, and then also different specialists within our health system. So I think creating that reconciliation and making the patients aware that their input is valuable and they can drive some of this change, I think that was really important. And obviously, like what Shan said about mobility, also very important. I think PTs identifying that people weren't safe to go before they left and needed supports was also crucial.
Mm-hmm. I think that's a really interesting point, Liz. I think many of us don't think about pharmacy assessment as being such an important of fall risk mitigation. I mean, I think I at least would point principally to a physiotherapist, but it's interesting that was your finding. And since most emergency departments, probably more emergency departments have a pharmacist in their department than a physiotherapist, it's an important tool to use. But over to Jessica, our physiotherapist, before coming back to you, Liz, to make a few comments about finances. So Jessica, what would you say, what advice would you give? I assume you would say, get a physiotherapist.
Of course, I'm going to say that. Physical therapy is important. However, I think that other specialties can kind of take the role on as well. There are certain things that a physical therapist can do that others can't. In our scope of care where I work, we can actually recommend people to subacute rehab straight from the ED, which actually prevents them from a hospital stay. I know in private sectors, they probably can't do that. I also think that there is a role in physical therapy, no matter what, whether it be in the outpatient setting or the home setting. It doesn't always necessarily have to occur in the ED as well.
Yeah, so from my experience, that's a big gain for having access to excellent physiotherapists and occupational therapists, is the possibility of completing most of the assessment to allow for a direct transfer to acute rehabilitation. We're fortunate to be able to have physiotherapy not in the department, but come down to assess our patients. And probably several times a week, we're able to move the person directly from the emergency department to rehab, avoiding a hospital stay completely. which I hope our hospital administration knows how much money and time and energy we're saving every time that happens. Back to you briefly, Liz. What can you say about budget, which is something that people are asking? I know you
Yeah,
put the
it's so
text.
important. I just want to state that our research was funded by a small project grant from the National Institute on Aging, and that did not cover an economic analysis, but we have gotten this question a lot, and we've actually done a back of the napkin analysis on this. And the main costs are obviously getting a physical therapist and pharmacist staffed in your emergency department. And so the cost to cover at least 2 FTE of each of those personnel, I think, are important. And we still found that for each patient seen, there was a $2,000 cost savings. And that primarily was to the fact that many older adults have mobility challenges. If they're admitted to the hospital, they kind of outstay their DRE welcome, so they stay a very long time, and the hospital might not be fully reimbursed for that stay. I would say that for the fee-for-service system like we are here in Rhode Island, the cost saving, it's a harder argument to make. However, if you are part of an ACO or you have based care systems at your health system, it's a much easier argument to make. So, and I know that Dr. Carpenter pointed out in the chat that Dr. Lauren Sutherland did an economic analysis of fall prevention measures and using a observation unit type approach, and there was cost savings there too. So I'd like to point people to that piece of research as well.
Yeah, good. Thanks for pointing that out. Also, to explore that, back in May, our last webinar, the financial benefit of a geriatric ED, we explored a lot of those. And if folks are interested in being able to be more knowledgeable about financial issues, I'd refer you to that previous webinar. Eula, are there any other questions that have come out of the chat just before we move on to final points?
Yeah, so so first of all, thank you to the 3 expert panelists. What amazing work that you've all done. And I think for many, the chat was very active today. So encourage everybody, if you have not been looking at the chat, to scroll up and just see all of the great dialogue that's been taking place. I think one question that was raised, and a couple of people who might be familiar with this, and it was posted in there. So Liz, I think the gap care, really remarkable. You've shown like a very practical approach, really pulling in many different parts of like the ED stay, like the physiologic evaluation of the patient, but pharmacist evaluation, and you showed an impact. We also know in parallel last year, a big study came out on the STRIDE study. And this was one not done in the ED, but done in the outpatient setting. Multiple centers across the country in the US really looking at falls prevention. And shockingly, they actually did not demonstrate really any change in outcome for patients who were part of the falls assessment program versus those that were randomized to not being it. Any thoughts from you, and also welcome any of the panelists, thoughts from you about the differences and the contrast and why yours had such a great impact and maybe why that one didn't?
Of course. So I think, the study that we did it's a pilot. It's 110 participants. Obviously, we're looking to do recruit many more people to make sure that what we see is still significant. But I think the ED is truly a moment. I think people come in and they're much more interested in hearing about how they can prevent falls because they're still in pain from their current fall. And a lot of times caregivers are present and physician available, as well as all of these other team members to sort of emphasize what can be changed. And we were really purposeful in designing our study so that while the patient is already waiting, they're waiting for imaging, they're waiting for labs to return, we're doing stuff to help them prevent future falls. So it didn't require any travel, it didn't require any extra costs on the behalf of the patient, and it didn't require all the logistics that are really hard for people with cognitive impairment or who've seen multiple specialists to do. So I think it's just the practicality of the emergency department setting where you already have interested patient population, and it can really serve as a hub to start fall prevention.
Yeah, so Chris Carpenter also texted into the comments about Stride that it didn't show a decrease in injurious falls, but in all falls. So even it did show a decrease in all falls. Relating to Jessica's comment about the importance of fear of falling, which is a very disabling thing in itself, probably there's an impact there as well. Just a reminder that the chat will be available on the website as well. So if there's resources in there that you're interested in, please come back to the website and you can access it there. So just before we wrap up, and Shan, I'd like to revisit your points and what are your main messages? You're on mute.
Yes, falls are common, they are costly, they're complicated, and we like to think of them as sentinel events, and that we have the ability to actually impact patients. Takeaway 2 would be that their falls are really a geriatric syndrome, and while challenging, we have a lot of we have hope that we actually can make a difference after hearing from my colleagues, Dr. Babbitt and Dr. Goldberg. And then takeaway 3 is, yes, there are many barriers, such as time and knowledge on the part of these ED physicians, but these can be overcome in many ways that we've seen how the ED has overcome many other challenges. So I would definitely say that these are vulnerable populations, and we need to find resources to actually impact their future fall rate.
Thank you. Next slide, Liz. Just to recap.
I think the takeaway from our pilot is that we can actually do something for falls in the emergency department more than just, placing referrals. And we can do it in a way that our ED directors and other leadership can be happy, because we don't necessarily need to increase length of stay. I think the second takeaway is that PTs are really helpful for determining how safe it is to even send patients home and getting buy-in for rehabilitation or outpatient PT if it's necessary. And the third takeaway is that maybe we should be thinking and talking more about motivational interviewing and involving our patients and their caregivers in the medications that they take, because we really have a polypharmacy crisis among older adults in America that needs to be addressed and impacts falls.
And finally, Jessica.
All right, so takeaway number 1, asking about details of a fall can definitely help you determine what you can do to help prevent them in the next fall. It'll help determine your next steps of action. Takeaway 2 is gait assessments are essential. They can even help determine diagnoses. You can also see if a patient needs alternate compensation, such as assisted devices. And then takeaway 3 is fear of falling is real. We do have to be cautious with the people who have fallen because they are fearful of it. And we have to gain trust with those patients.
Good. Thank you very much, Jessica and everyone. We've had our question and answer. I wish it could have been longer. We just want to highlight a few other resources that the GEDC makes available to you. We now have access to Christina Shenvy's wonderful set of GEMcasts, so podcasts about GERI-EM topics. This is a whole one about banning the use of the term mechanical fall and really digging down around fall assessment. Next slide, please. I draw your attention to this Made in Toronto podcast called EM Cases, and it deals with clinical topics in emergency medicine. The last 2 podcasts have been specifically around geriatric trauma and geriatric falls. Next one. And our resource library and GEDC website is full of resources that are available to you around different things you can do, including a full curriculum co-hosted with the American Geriatric Society on falls and safe mobility. And on that word of mobility, I do just want to thank Jane Carmody for putting in the 4 M's link. Remember, assessing falls appropriately is about improving, maintaining mobility among older people, which is one of the essential components of an age-friendly health system. Next slide. Please come back to us again in a few weeks, early November. Tony Rosen, and one of America's leading experts on elder abuse, and I will be co-hosting an expert panel on elder abuse and neglect. Next slide, please. You know where to find us. And final slide. Thanks once again to Donna Hartford Foundation and West Health for their support. And a very special thanks to our three guests, Dr. Shan Liu, Liz Goldberg, and Jessica Babbitt. I think we've all benefited from your contributions, and more importantly, the older people of the world have benefited from your presentations. So we'll look forward to seeing you again in a few weeks. Thanks for being with us. Bye all.